So put people first, as I understand, is that what one of our advocates used to say when people say nothing for us without us. Huh? So whatever policy, whatever implementation framework, whatever you as policymakers, program manager decide to do, have sort of a consent of people who need people who need those services. So that's one aspect of put people first, which is that they are part of your policy making, they are a part of your implementation. They can also be part of your monitoring and evaluation and feedback framework, and they can also contribute to decision making. But when you move to public health, it's a larger universe there. And in that larger universe, you realize there are many patients who are not, many people with symptoms who are not seeking care. And the challenge is to reach those people. And that those challenges are surmountable to a large extent. But having said that, you still keep on missing people. And it is the deaths among these missing people are a large proportion of the total deaths which we see, not trying to undermine or understate that deaths do not occur among those people who are under care. Deaths do occur even among those people who are under care, but if you see a large portion of death is those who have not sought care, or those who have not been diagnosed at all. So the first paradigm of reducing death is reach out to everybody, diagnose everybody. And like you rightly say, find all people with HIV, AIDS, TB, or any other disease. So that's the first dictum when you are on the public health side. Second is what most TB programs have now started doing is that they have started now screening with X-rays as a screening test, not as a diagnostic test. So they scan you through an X-ray. If there is a shadow in an X-ray which is suspicious of TB or any other lung disease, then investigate them further. So this paradigm can be changed for PLHIVs. You can do that at least once a year with screening with X-rays. That will help you to catch them earlier. They may not be symptomatic. Every person may not actually report asymptomatic. So you get them at an early stage, what we sometimes call as subclinical TB. It can be picked up by X-ray and then investigated further.
So welcome friends to another episode of Put People First series in the lead up to 25th International AIDS Conference or AIDS 2024 in Munich, Germany. Today we have amongst us Dr. Kuldeep Singh Sachdeva ji. Dr. Sachdeva is a known name, a signature for sincerity and integrity when it comes to health responses. He has played a pivotal role in shaping India's national TB program. Spend, I think, sir, please correct me, maybe about 2 decades at the National TB Elimination Program, which is the Indian government's national TB program. She also served as Deputy Director General at the National AIDS Control Program of the Government of India. People who do well, sir, they get more responsibilities. So you shouldered the responsibility of Southeast Asia Regional Director at the International Union Against Tuberculosis and Lung Disease, the Union. And currently he's serving as the president and CMO of Molbio Diagnostics, and calling upon the governments globally, I guess, so that we can find all TB and reach to the people who are currently unreached with the diagnostic services. Finding the diseases, sir, is also so important when we want to stop the misuse and overuse of medicines. So as the governments and the world leaders meet at the antimicrobial resistance UN high-level meeting, I think diagnostic stewardship is so critical to, if we are to address AMR. So with these opening words, sir, we welcome you. Thank you so much for giving us your time, sir.
Thank you, Bobby, and good morning, good afternoon, good evening to all friends and colleagues across the globe. Very delighted to be part of this meeting and look forward to a good interaction with you, Bobby, and the community in general. Yeah.
Yeah, thank you, sir. When we look back at TB and HIV programs, sir, we say that no one should die of TB or AIDS. We have the tools, but I think 630,000 people died of AIDS in 2022. 1.3 million died of TB in 2022, and 167,000 died of the co-infection. Sir, your opening remarks of how could we have done better?
I mean, that remains the sad part of the programming for both TB, HIV, AIDS, and so many other diseases that people still continue to die. And that is where the programs need to do much better, reach out to people. I'll try to give you a parallel. Like I was a clinician early for almost 20 years of my earlier career in a tertiary care hospital, and we used to see patients. So it's a more 1:1 interaction when you see patients who come to you. They, of their own volition and based because of their own disease, have decided to seek care. And those who seek care are also more sort of uh, mentally prepared to accept what you are trying to tell them and what their disease is, react to it, be more adherent to drugs, and so on and so forth. So a part of response is assumed that patient will be, or the let's not use the word patient, the person with the disease will be more understanding, will be cooperating with the physician, and so on and so forth. Having said that, when you move to public health, so in 1:1 interaction, you also feel the emotions and other things of the patient. But when you move to public health, it's a larger universe there. And in that larger universe, you realize there are many patients who are not, many people with symptoms who are not seeking care. And the challenge is to reach those people. And that those challenges are surmountable to a large extent. But having said that, you still keep on missing people. And it is the deaths among these missing people are a large proportion of the total deaths which we see, not trying to undermine or understate that deaths do not occur among those people who are under care. Deaths do occur even among those people who are under care, but if you see a large portion of death is those who have not sought care, or those who have not been diagnosed at all. So the first paradigm of reducing death is reach out to everybody, diagnose everybody, and like you rightly say, find all people with HIV, AIDS, TB, or any other disease. So that's the first dictum when you are on the public health side. The second part of those who die while they are under care, even patients who seek 1:1 consultation with the physician sometimes will have that unfavorable outcome. That is where probably you need to be more vigilant of other disease profiles in those patients, how far the disease has progressed, at what stage of the disease they have reported. Do you need to stick to the conventional protocolized treatment, or do you need to individualize treatment for that particular person? So what is known as a differentiated care. So there are two things. On the one side, those who are missing care, find all of them, reach out to them. Those who are with you in the system, can you offer them better care? Which I will use the word differentiated care, quality of care, but care sometimes beyond protocolized treatment. Can you handhold them in their journey towards cure? They they may not, they may be responding well, but their social circumstances may be such that they are not able to be sort of adherent to treatment. So there's another paradigm where you need to support them with out-of-pocket expenses and so on and so forth. I'm not elaborating on so many things which can be done with them. But these are two different set of people. Of course, the challenge is on all of us to, one, find all, treat all. Second, those who come under care, give them an individualized, personalized care, look after them well, try to meet their social circumstances to the extent possible, give them moral support and the support that they need from us. And then we will definitely, if we are able to do that, we will be able to sort of cut mortality to some extent. Though absolutely bringing it to zero may be very difficult because of the disease profile itself or the host response itself in some of the patients, some of the people. Yeah.
Yes, sir. So thanks a lot, sir, for helping us understand this. Sir, looking at TB, how we find TB among people living with HIV. So please help us understand. How can we do better in terms of finding TB among people living with HIV, finding it early and accurately, and also, sir, in context of extrapulmonary TB, because that is also a huge challenge for people living with HIV. Thank you.
Thanks, Bobby. So the point here to note is that over last 2 decades or so, since 2000, the paradigm of how do you find people with TB is also changing. The earlier paradigm which I referred is when you sit in 4 walls of your chamber, patients are or people are sick and they come and see, which is called passive case finding. So people are coming because of their illness. You run a battery of tests and then you diagnose them. That's passive case finding. Over a period of time, people realized, the community of public health practitioners realized, but that is how not you are not going to reach everybody. So they brought in a new paradigm called intensified case finding, which is people who are already under your care. Can you look in TB for those patients who don't have TB, but they are under your care for different reasons? And the prime example is PLHIV. So PLHIV are under your care for because of the HIV infection, and you're treating them for HIV infection. So intensified case finding, particularly for TB in these patients, is that you screen them for TB on every visit. Screen them for TB on every visit, and then sort of diagnose them. Now the screening paradigms are also changing over last 2 decades. The first paradigm was screen by asking them symptoms. So TB symptoms are 2 weeks of cough, fever, more than 2 weeks, chest pain, blood in your sputum, etc., etc. So first paradigm change in HIV was relax those symptoms, make it cough of any duration. So don't wait for 2 weeks, reduce it. That was the first paradigm in intensified case finding. The second paradigm was reach out to them, all PLHIVs. One, which are under your care, not only in institutionalized setting, but who are under your care outside institutionalized settings or community settings, and screen them at regular intervals. Draw any sort of a periodicity for them, at what intervals you would like to screen them, monthly when they come for drug refill, or quarterly or 6 monthly. That depends upon your resources and both human and financial, and the how can you afford to do that. Once you define the periodicity, again, then now the paradigms will be how do you screen. One is verbal screening, which HIV programs have been doing for years, which is the most easiest because it doesn't consume any resources. Second is what most TB programs have now started doing, is that they have started now screening with X-rays as a screening test, not as a diagnostic test. So they scan you through an X-ray. If there is a shadow in an X-ray which is suspicious of TB or any other lung disease, then investigate them further. So this paradigm can be changed for PLHIVs. You can do that at least once a year with screening with X-rays. That will help you to catch them earlier. They may not be symptomatic. Every person may not actually report asymptomatic. So you get them at an early stage, what we sometimes call as subclinical TB. It can be picked up by X-ray and then investigated further. So that is another change or more if you would like to do for those patients, you can do. It is also, in other words, an active case finding. So from passive case finding to intensified case finding, which is verbal screening, would be an active case finding in a group which is sort of under your care. You're not going to community to do active case finding, but these people are under your radar. They are diagnosed PLHIV. So you can actually shift the paradigm of screening them for TB from an passive to intensified to active. Very easy because it's a very small group of people. In any country, the PLHIV will be a small percentage of the total population. So you're not screening the total population. Doable in terms of resources. So if you move to an active case finding, define the frequency of that, maybe yearly, or anytime they report symptoms. So that will also allow you to reach them early, diagnose them early, and your first question, reduce deaths or mortality among such patients. So that's another paradigm. The third paradigm, which people are trying to do, but it's very resource intensive, is there are two subsets. One is define the risk profiling. So, do they have any other risk? Are they smokers? Do they have diabetes? Are they exposed to silica dust? Any occupational lung disease? So on and so forth. You can define the risk profiling. And when you or do they live in areas which are difficult to release? Or do they belong to a population which feels marginalized and hence do not seek care? Do they live in crowded environments, hence more exposed to transmission? So once you do risk profiling of the entire community, generally in our country, when we did the risk profiling, it's about 10 to 15% of the population which falls into this risk profiling. Okay, so again, a smaller subset of the population which you need to do an active case finding in such population based on preferably on a X-ray which can be carried to the community. So you also sort of save them of out-of-pocket expenses. You're also more closer, more easy to sort of convince, talk to them, handhold them to do that screening. The last one, which is very difficult to implement on ground, but maybe a time will tell at some point of time, can we do it in some pockets, which India has done in some pockets, is screen the entire population over the years and drastically reduce the incidence of TB, which they have specifically, people are looking at closed geographical areas, like we had an island called Lakshadweep, or some hilly terrains like Budgam and Jammu and Kashmir, which are close geographical areas, practically cut off from other people, not much of migration. You can start showing models of elimination in those areas, but that's a holistic, very, very heavy resource intensive, uh, where you may have to look at certain classified geographies. You may not be able to do it everywhere, but you can attempt in certain classified geographies. Island nations like Philippines, you showed one example, one island in Bantayan. So you can actually screen those small pockets and demonstrate it's doable. So these are various models to sort of reach the unreached population and drastically find TB in all. In PLHIV, it will be much easier because that subset of population is much smaller.
Yeah, yes, sir. We totally agree with you. Yeah. And also, sir, people with HIV are on lifelong antiretroviral therapy. So you're
Yeah.
very right, sir. It is such a doable thing and such high value in terms of public health as TB risk is very high. Can you, sir, please emphasize more on what can we do to reduce the risk of TB among people living with HIV?
So to reduce the, I'll talk of this subset of population, which is PLHIV and their risk of TB. The difference treatment as a prevention was the first paradigm of TB care and control, which has now been expanded a lot because the practitioners soon realized even if you get everybody on treatment, you are not going to end the TB epidemic because it's a communicable disease which actually is airborne. So the communication is through, the transmission is through air, unlike HIV/AIDS, where you need a close contact or a blood transfer or something like an injecting drug use, etc. So there you can define more community more clearly, which is, and you can sort of know the risk, do the risk profiling and make a very focused way to do that things. Unfortunately, in TB, I mean, one of the most generalizable thing is that if you are alive and breathing, you are at risk of TB because you are inhaling air. So, which is not the case for TBs. They may be alive and breathing, but they are not at risk of HIV, sorry, which is HIV. So, having said that, within the same paradigm, we can also sort of educate, counsel both the people living with HIV as well as the system itself, how they can prevent occurrence of TB in PLHIV. One, wherever the PLHIVs visit, those areas need to be compliant with the airborne infection control guidelines. I'll not elaborate into because that is a different subject on airborne infection control guidelines and it will stretch a bit. But if you are compliant with all institutions or places where PLHIVs go with the airborne infection control guidelines and the airflow patterns, we'll be able to reduce that to an extent. And that applies to hospital settings, outpatient departments, inpatient wards, community care centers. That's number one. Number two, if PLHIVs travel to crowded places, I mean, they will also move out of institution. They're part of the general community. They'll also move out of the institution, interact with people, go on public transport, etc. This precaution would come for people living with PLHIV that they can use some kind of a mask so that they don't directly inhale the air whichever, because you can't, in a crowded place, you can't make out which person has TB, which doesn't have TB, nor it is advisable to do that because you will be stigmatizing them around. So it's better that you err on the side of caution. So if people with HIV, living with HIV, err on the side of caution and avoid crowded places. If you cannot avoid crowded places, wear a mask. So that will help them to an extent to less. Third is that keep adherent to treatment, keep monitoring your viral load, keep monitoring your CD4 counts, and you know whether you are getting prone and do you need to change treatment for HIV or be more adherent and so on and so forth, or are you failing first line HIV treatment? So that again, that's both on system as well as on people living with HIV that they need to have a careful watch on the progress or stability of their disease. If not progress of the disease, you should know that you have to keep yourself stable on those parameters. They should not deteriorate on the downside. So they should not get worse. So if you are stable enough, your chances of getting TB then get almost reach that of the general population, which probably is the best that you can do as a PLHIV yourself, and the system can offer that support to you. And of course, all other respiratory hygiene measures. If you are coughing, put your hand or elbow or a handkerchief so that you are not spreading. Spread the same cough hygiene in the general community, etc. For policymakers to not avoid spitting in open public spaces, etc. Use cough hygiene. All those measures can be a great help, though not totally eliminate the chances of, but they can be of great help in preventing the spread of TB.
Yes, sir. Thank you. Let's hope that we are able to reduce or bring TB transmission or TB risk or TB acquisition among people living with HIV and general population to zero, or as low as possible. And especially for people living with HIV. Thanks a lot for reinforcing that message that if they are on treatment, if they are virally suppressed, their risk of TB and other opportunistic infections will be so low. And of course, with regular monitoring, probably things can be way different in terms of long-term HIV care outcome. I think we need to do more as programmatically also focus more now on long-term HIV care outcomes for people living with HIV, and TB surely should be one of the things to look at. Sir, coming towards the end of this, sorry to take so much of your time today. Can you please, as you know, put people first as the theme of the upcoming AIDS 2024 conference? And so what does put people first mean to you?
Put people first, as I understand, is that what one of our advocates used to say when people say nothing for us without us. Huh? So whatever policy, whatever implementation framework, whatever you as policymakers, program managers decide to do, have sort of a consent of people who need that, people who need those services. So that's one aspect of put people first, which is that they are part of your policy making, they are a part of your implementation. They can also be part of your monitoring and evaluation and feedback framework, and they can also contribute to decision making. So that's one paradigm of putting people first. The other paradigm of putting people first is such people may have their own unique individual need, which people living with those diseases may not have. And they may sort of, in terms of pure equity, not equality, in terms of equity, they may need disproportionate amount of attention or resources compared to a person next to them living without a disease. So see to it that you are able to give them their right due in that aspect also. Say if they are not able to assess care, then you sort of allow them transportation or meet out-of-pocket expenditures, meet catastrophic costs, put something in their pocket or put something on table which helps them to sort of fight their status with dignity. So that's the another paradigm of putting people first. So first is they have a say in this thing. They also have some say in disproportionate resource utilization. You are also able to put something on table. I'm cognizant of the fact that policymakers may not be able to do it in totality, but you are able to meet some of the catastrophic costs. And I mean, the paradigm is that there should be zero catastrophic costs. You should be able to meet. Again, they are a very small subset of the population per se. It's not the entire population of the globe. You should be able to meet. And there are brilliant examples in many programs on how they have been able to meet those catastrophic costs. The other is also on stigma and discrimination. Treat them like normal people, have a conversation which is more universally acceptable. They are treated with dignity, respect, and as any other member of the population. So that's the third paradigm of putting people first. Also, programs, policymakers must ensure that resources are available, drugs are available, diagnostics are available, preventive treatments are available. They are educated on that. They are sort of counseled, and there is an advocacy on that. If they need hand holding, so there is some level of healthcare support which is available to them. So that's another paradigm of putting people first. And the last is in the research and development. When new treatments are coming, and new vaccines are coming, and new drugs are being discovered, keep them in mind that they'll be the ultimate beneficiaries and users of those new treatments. They allay their fears, keep them in the development process, involve them in that same. So that's also from a futuristic point of view, that is also very important. And the ultimate is for specifically for PLHIV is not so much for other curable diseases, but watch for their chronic diseases, any comorbidities. Try to meet them and treat them and make them be as living life as near normal as possible and feasible, both from the science aspect of it, also from the society aspect. So that's how I understand put people first.
Yeah, thank you. Thank you so much, sir. Only one word, amen. I think all what you have just said should be happening, should be true. It is so important that people remain central to the health responses. Again, very grateful, sir, to have this conversation with you. Thanks a lot, and I hope it would have stimulated a lot of ideas and, of course, a very rich conversation, and probably will help, improve responses, not only TB, HIV, but other health responses. Have a great conference in Munich, Germany, sir, later this month. And I should have wished you before, but let me wish you now a very happy Doctors' Day. Today is National Doctors' Day in India, the birthday, and probably we lost Dr. B.C. Roy today also, the same day for both. But Dr. B.C. Roy Sahab's contribution to medicine and health is really legendary, and India observes its Doctors' Day. And you definitely have, kept the values which Dr. Roy upheld so close to your heart, not only when you were serving as a clinician, at a tertiary care hospital in Delhi for 2 decades, but also the other 2 decades where you have been helping shape programs. Thanks a lot, sir. All the best. Thank you very much.
Thank you, Bobby. Thank you, and have a good day.
Thank you.